right now? Okay.
So we're just going to be talking a very condensed version of a discussion about the management of preterm labor. And the reason this is so important is because of the burden on the healthcare system, as well as just the emotional impact of these outcomes. It's 12% of all live births, but comprises 75% of neonatal mortality. It also has 50% long-term neurologic disability. It's one of the leading causes of cerebral palsy and is responsible for a third of healthcare costs for infants, over 6 billion annually. And in 2016, sort of a benchmark study, 25 billion in total in related costs were related to preterm birth. By comparison, babies born between 23 and 27 weeks cost 28 times that of newborns. So it's just a significant burden. This is a slide that just totally depresses me because it shows we're really not advancing the game on reducing the incidence of preterm delivery. There's a lot of possible explanations for this. It's multifactorial, but the message here is that we're not really having much of an impact on the incidence of preterm delivery. There's also a significant racial disparity, and so this is something that we focused on a lot over the last several decades because it's clear there's a disparity. And so if we start to look at explanations for why this happens, we see that it really is multifactorial. Now, some of it is actually intentional. What do we mean by that? Well, people who get severe preeclampsia or have severe growth restricted fetuses, they're often intentionally delivered early to prevent stillbirth. So that's part of it. Multiple gestation is a significant contributor. And then we get into more medical issues like infection. So ascending infection into the uterus is a significant contributor. Abnormal placentation, placenta previa, poorly implanted placentas, uterine anomalies, something like a bicornuate uterus, and then socioeconomic factors are significant contributors. So we sort of have divided our approach to this problem into two groups. One is to try to predict who might be at risk for going into labor early. And then secondly, how do we diagnose it when it actually happens? So 43% of preterm delivery is spontaneous preterm labor. 32% is ruptured membranes in the absence of labor. And then 25% is what we were discussing before, an indicated preterm delivery. So what are some predictors of preterm labor? We've used risk scoring indices, microbiological tests. For a while, home monitoring was in use. That's fallen out of favor, as has salivary estriol. We still use cervical links, and then fetal fibronectin kind of has a plus minus use. So we actually offer cervical link screening for every patient we do an ultrasound on. So when patients present with a short cervix, this could be a marker of uterine activity. It may tell us that they've been contracting and haven't even realized it. It could be an indication of inadequate reserve for normal contractions, albeit they have a what we might call a cervical incompetence. And then when it does get short, we worry that they may have an inadequate barrier between the sterile intrauterine environment and the natural world of the birth canal. So what is a normal cervical length? We will quote usually like 3.5 centimeters at the mid portion of pregnancy. This is just a distribution of cervical links in a normal population of pregnant patients. And it's important to know that there's a natural shortening of the cervix throughout pregnancy. We really don't start to assess the cervical length before 16 weeks for the simple reason it really hasn't been defined. What is the cervix versus the lower uterine segment until the fetus reaches about a 16-week size. So the 10th percentile for cervical lengths in that bar graph I was showing you is 2.5 centimeters, and that's a frequently used cutoff to define what is short. The 90th percentile is 4.5 centimeters. So why do we care about cervical length? Largely because of what this graph is showing, that as the cervix gets shorter, the relative risk of preterm delivery escalates dramatically. So this is a graph that was presented in Jay Iam's paper in the New England Journal in 1996. And I probably stared at this graph for years before something struck me that I'd never seen before. And it's, if you look at the relative risk of cervical length of 40 millimeters, so this is above average, that population has a relative risk of 2. So a doubling of the risk of preterm delivery with an above average cervical length. So this tells me they were studying a population of patients that must have had a very high risk of preterm delivery. This is just a graph of the performance of cervical length as a test. So the sensitivity, specificity, positive and negative predictive value. What is good is the negative predictive value. So that tells me I might be able to use a normal cervical length to draw some conclusions, but the positive predictive value is actually very low. So I may be limited in how much I can say about a short cervix. And I also just included the same information for the Bishop score, and you see, that's actually very similar to what the cervical length is telling us. So just a word of caution about how you would interpret these results. I throw this in just as a comparison. This was a study of cervical lengths in the UK, and they came up with a very different cutoff than we did. So for their population, 1.5 centimeters rather than 2.5 in the US was the best discriminator of an increased risk of preterm delivery. And this is the ROC curve that they generated. And so you can see how their curve has maximal prediction at 1.5 versus 2.5. So when we're looking at a cervix on transvaginal ultrasound, one of the important aspects, in addition to just the length itself, is the appearance of the internal os, because this is sort of the business end of the cervix, if you will. The internal os changes before the external os. So all those decades and decades of assessing the cervix externally really were missing sort of the action end of the cervix. So trust your vaginal ultrasound will demonstrate the progression of cervical change before the cervical change actually becomes clinically detectable. Now, there's some important pitfalls to know, things that can give you false information. So as I said before, we don't even start measuring it really until 16 weeks. If someone has had prior cervical surgery, like a conization or a LEEP procedure, their cervix may actually be anatomically short, but it could be functionally normal. And that's, again, where looking at the internal os could be helpful. They may have a cervical length of 2 centimeters, which is short, but their internal os could be completely closed, indicating they may have a completely normal pregnancy. If the bladder is overfilled, that can falsely compress the lower uterine segment and elongate the measured cervical length. Same thing could happen with excessive probe pressure and uterine anomalies, fibroid tumors, or even something as common as a uterine contraction could affect how you measure the cervical length. So what do we do for a cervical length under 2.5 centimeters? There are a couple of possible approaches. You could consider placing a cerclage. The literature is conflicted on that. You could prescribe vaginal progesterone. You could monitor for preterm labor. You could look for underlying causes such as infection, maternal disease like poorly controlled diabetes or hypertension, sources of stress in the patient's life. And then you might just opt based on the European data. You might say, well, we're just going to do serial cervical length measurements and see what happens over time. So in a meta-analysis of cerclages from 4 randomized trials, they concluded that there was no benefit found for the total population. A subgroup analysis suggested there could be benefit for 2 groups, those with a history of a prior preterm delivery and those with prior second trimester losses. They also found that there was a doubling of the incidence of preterm delivery when cerclages were placed in pregnancies with twins. So caution with twins. Just briefly to mention fetal fibronectin, though its use has really reduced dramatically. Much like the cervical length, the value of a fetal fibronectin may be in its negative predictive value. So it has a fairly high negative predictive value and a low positive predictive value. So really the utility might be when you get a negative test, it may give you the freedom to do things like reduced surveillance, discharging patients from the hospital, things of that nature. So what about preventing preterm birth? I've already suggested that we're not doing a great job with that. Is there anything at all that can help? And the answer is possibly. There's been a lot of evidence that has suggested progesterone can prevent preterm birth in specific high-risk situations. Those with a short cervix where vaginal progesterone has been shown to be helpful, and those with a prior history of a preterm birth. Clearly, progesterone is not effective for these populations. Multiple pregnancies doesn't help with twins. Preterm labor that's already been diagnosed, it does not treat preterm labor. It's not going to make them stop contracting. And then prior preterm birth, but a normal cervical length, probably not going to be helpful. So the route of administration can be important. Vaginal progesterone has the most evidence of effectiveness for women with a short cervix. Injectable progesterone has faced scrutiny and is no longer broadly recommended. So there was a meta-analysis of 17-hydroxyprogesterone, 5 trials, high-risk pregnancies, produced results that showed a reduction of preterm birth in certain populations and reduction in low birth weight babies. This was published back in 1990. Then the Maternal Fetal Network did a trial, placebo-controlled, randomized, sort of gold standard trial, where they took women with a history of prior preterm delivery and randomized them to get weekly injections of progesterone beginning before 20 weeks and continuing up until delivery or 37 weeks. And they showed a significant reduction of preterm delivery in this high-risk population. This has been referred to as the Meese trial based on the lead author, Paul Meese from Wake Forest. Then years later, a second trial was conducted. It was an international trial, a much larger trial, 1,700 women with a history of a spontaneous preterm birth, 93 sites, 9 countries, about 25% of the subjects were in the United States. And bottom line, this study showed no difference in preterm birth rates for birth before 35 weeks. This is just a table showing the MEIS trial compared to the prolonged trial. So the prolonged trial was much larger, international. Some people said, well, yeah, but you're studying a different population when you include like European centers. And that's certainly true. That's what we saw with the cervical link trial out of the UK. So they selected out the US part of the prolonged trial and showed it, that even that group did not demonstrate significance. So not helpful in the prolonged trial, but helpful in the MEIS trial. How can you explain that difference? So then what are we to do with that information? So here are all the new treatments for preterm labor. There are none. Things that are still being used: magnesium sulfate, calcium channel blockers, beta mimetics, very rare, non-steroidal anti-inflammatory drugs such as indomethacin or ibuprofen. The oxytocin antagonist atozoband did not get FDA approval in the US because of a finding of a higher death rate in extremely premature newborns, but it did get approval in Europe. And I was curious, what have they found? They've been using it for the last couple of decades, and a recent trial in Europe showed it really was not helpful. This may be the most important thing to say, whereas our treatments really aren't effective for more than 24 to 48 hours. Clearly, betamethasone or glucocorticoids are significant in their ability to reduce adverse outcome in the premature neonate. So absolutely remember to give this medication in any patient you think may be at risk for preterm delivery. So just in summary, cervical length can predict a risk of preterm delivery. It has a very high negative predictive value. So when you see a normal cervical length, you can feel reassured, but the positive predictive value is poor. A single measurement at around 22 weeks seems to be most cost effective. We tend to do it when patients come for their anatomy scan, which is usually somewhere between 20 and 22 weeks. Serial measurements of cervical length may improve detection in high-risk patients. Fetal fibronectin can complement a cervical length, again, because of its excellent negative predictive value. A positive fetal fibronectin funneling, dynamic change all increase the risk of preterm delivery in patients with a short cervix. Clinical history remains the most useful diagnostic tool to find patients who have an incompetent cervix. Progressive cervical shortening combined with a history of recurrent mid-trimester loss suggests the possibility of cervical incompetence. CERCLAS trials show no benefit for low-risk patients with a short cervix, but possible benefit for high-risk singletons, and remember, may be harmful for twins. Progesterone shows promise for some patients with a history of preterm delivery, but not proven helpful for patients in active preterm labor, and no benefit again for twins. Tocolytic therapy remains largely unhelpful beyond 24 hours. Some patients in some situations may benefit, but such patients are difficult to identify. Remember that corticosteroid therapy is the single most important entity in our approach to preterm labor, preterm delivery, so ensure its liberal use. Studies pending on how much repeat dosing is helpful. So let me just stop at that point and see if any